This is Dr. Elisa Pallares Vela, and today I will be using traumatic brain injury as an example of why it is time for brain medicine. So, TBIs can be caused by any forceful blow to the head or from any object piercing the skull and entering the brain. Some TBIs can cause short term problems, and other ones can be more severe and cause permanent disability or death. In the United States in 2021, there were about 190 deaths per day related to TBI injury. And in 2019, there were 223,000 TBI related hospitalizations. As we can see through the different years, the rates have remained the same almost throughout the year. So there are many ways of dividing TBIs. When we talk about the type, we can say penetrating or non-penetrating. Penetrating means that an object is piercing the skull and entering to the brain tissue, and it typically damages only a part of the brain. Whereas non-penetrating is caused by any external force that is strong enough to move the brain within the skull to cause damage. We can also divide them in the time course, primary and secondary. So primary means the damage is direct and immediate, whereas secondary symptoms occur gradually over the course of hours, days, or sometimes even weeks. So it's a result of a reactive process after the initial trauma. There is a wide variety of symptoms that can appear with a TBI. Some of them are headaches, seizures, anisocoria, diplopia, CSF leakages from the ears, from the nose, nausea and vomiting, and any new neurologic deficit such as slurred speech, weakness of the extremities, loss of balance, among others. There's also some cognitive and behavioral implications of TBI. So there may be loss or changes in consciousness. We can measure it with the Glasgow Coma score in the emergency room. Also, confusion, disorientations, memory problems, problems with concentration, decision making, changes in the sleep patterns, as well as mood changes, irritability, anxiety, depression, feeling drowsy, and sensitivity to light or sound. There's many symptoms that can appear. There may also be blurred vision, hearing problems, tinnitus, bad taste in the mouth, among others. So, as we know in neurology, there's a localization to lesions. For example, if we get a TBI in the frontal lobe, we will get less of focus, irritability, and language difficulty. If it's in the parietal lobe, we will get difficulty with reading and spatial misperception. If it's the temporal lobe, our memory will be impaired. If it's occipital, we'll have vision problems. Cerebellum will be difficulty walking and slurred speech, and the brainstem controls breathing and a steady heart, so we can get changes in breathing and difficulty swallowing. There are many consequences that TBIs can bring. Some of the primary effects are diffuse axonal injury, where there's a widespread damage to the brain's white matter. Also concussions, contusions, skull fractures, hematomas, chronic traumatic encephalopathy, which is a progressive neurological disorder associated with problems with thinking, understanding, communication, motor disorders, impulsivity, depression, confusion, irritability, among others. And also post-traumatic dementia. There can also be a secondary damage. So this means the damage will take place after the injury. It can be due to hemorrhagic progression of a concussion, a breakdown in the blood-brain barrier causing swelling, and increased ICP. And so the damage will depend on the brain of the area that is damaged. There are some severe consequences that can be present with TBI: coma, vegetative state, minimally conscious state, and brain death. So when a person is in a coma, the person is totally unconscious, unaware, and unable to respond to any external stimuli, such as pain or light. A coma generally lasts a few days or weeks after, the person may regain consciousness, die, or move into a vegetative state. Vegetative state also takes place when there's a widespread damage. And these people are usually unconscious and unaware of their surroundings, but they do have some periods of time where they have a certain amount of alertiveness and they may groan, move, or show some reflex responses, as we can see here in the table. Here there's nothing, and here there's some. And then we move on to the minimally conscious state. So people have like severe altered consciousness, but they still display evidence of self-awareness or awareness of their environment. Brain death is when there is the lack of measurable brain function and activity after an extended period of time. So, how do we do a diagnosis of a TBI? It's important to know that all TBIs require immediate assessment by a professional who has experience evaluating head injuries. It's crucial to take a good history, including risk factors that can impact on the recovery length. For example, history of previous concussions, history of headaches, or any psychiatric illnesses that the patient had already. We also need to do a thorough neurological examination to examine for consciousness, hearing, speech, coordination, balance, mental status, any behavioral changes, among other abilities. And then we can also support our diagnosis with imaging. So CT scan will be really good as a first test when we want to see if there's an acute bleeding or a skull fractures. So we would do a non-contrast CT scan. And then magnetic resonance imaging, MRIs, and they produce more detailed images of the brain tissue. So it's more sensitive to see the brain structures, and it will also help us see any old bleeds. So it can also be classified by its severity. We can have mild versus moderate and severe. So in a mild TBI, the Glasgow Coma Scale will be between 13 and 15. The duration of the unconsciousness is less than 30 minutes, and amnesia lasts for less than 24 hours. It's considered moderate when the Glasgow Coma Score is between 9 and 12. The amnesia lasts between 1 to 7 days, and the duration of unconsciousness is less than 24 hours but more than 30 minutes. And it's considered severe when it exceeds any of these two parameters, and the Glasgow Coma Score is between 3 and 8. So what are some of the symptoms of mild TBI? So these people may be bothered by any light or noise, feeling dizzy, feeling tiredness, having headaches, nausea, vomiting, vision problems. They will also get problems with concentration, feeling a little slowed down or groggy, problems with short or long-term memory, trouble thinking clearly, feelings of anxious, like feeling anxious, depressed, more emotional than usual, and it will also have impact on the sleep. It can go either way, so they sleep less than usual or more than usual. So when should we seek for immediate attention after a mild TBI? If there's any worsening or persistent headaches, a patient has weakness or numbness, decreased coordination, seizures, keeps vomiting, has like slurred speech or any new neurological deficit, anisocoria, cannot recognize people or places, or there's a change in the alertness of the patient. So how do these people recover? So recovering from a mild TBI will take a couple of days to a couple of weeks, varying on the patient. So the first few days, you should take it easy. Even if you don't have symptoms, you should take it easy and make sure to take a couple of days off the activities. After you start feeling better, you have to gradually return to the regular non-strenuous activities. And it's suggested to avoid any activity that make your symptoms come back or get worse. When the symptoms are nearly gone, you can start returning to other regular activities you need to do. It's also important to talk to patients about sleep hygiene if they're having sleeping problems, and having support from the family and friends can help with the recovery as well. The treatment varies among every patient. So some patients may only require over-the-counter pain relievers and that's it. It's always important to monitor and find any worsening symptoms. If it's sports related, we should quit doing it until the concussion injury specialist tells you it's okay to do it. Prevent future concussions is critical. It has been proved that the rate of recovery from a second concussion or third concussion is generally slower than the first one. And even if symptoms resolved entirely, you have to return to the activities gradually, as we said before. There are some cases that we may need other pharmacological treatment for people with a mild TBI. So when we talk about moderate to severe TBI, the symptoms are a little more dramatic, to say so. So these people can have focal neurological deficits, impact on their motor skills, hearing, and vision. Problems with coordination are much more frequent, difficulty understanding and thinking clearly, trouble communicating. It's really hard to learn like new skills, problems concentrating, as well as emotional changes like nervousness, anxiety, feeling more emotional, even aggressive, more aggressive than usual, impulsive, trouble controlling these behaviors, personality changes. So these are all symptoms that could appear in a moderate to severe TBI. The treatment of moderate to severe TBI often needs specialized medical care. Rehabilitation is very important because they need to relearn skills that they have forgotten. We need to screen and treat for depression, educate on the problems that may show after the injury, like chronic pain and headaches, and educating not only the patient, but the family as well. They need family and social support. There are also long-term negative effects of TBI. So this is from the CDC, and they say that after surviving a moderate or severe TBI and receiving inpatient rehabilitation, the life expectancy of that person is 9 years shorter than the general population. They also have increased risk of dying for several causes. They're 50 times more likely to die from seizures, 11 times more likely to die from drug poisoning, 9 times more likely to die from infections, and 6 times more likely to die from pneumonia. When we check on the 5-year outcomes of persons with TBI, 22% died, 30% became worse, 22% stayed the same, and 26% improved. A person that has a moderate or severe TBI may need ongoing care to help with the recovery. And the lifetime economic cost of a TBI, including all the direct and indirect medical costs, is really high. So we can see how many brain-related disorders have neurological and behavioral consequences, and it's important to address both. So why is it time for brain medicine? I decided to use TBI as one of the many existing examples of why it's important to have knowledge in both neurology and psychiatry when dealing with patients with brain issues. So the point I want to get to is that it is important to have a good preparation in both to give a better care for the patients. I have always been interested in neurosciences, particularly in the behavioral area, and I want to pursue a psychiatry residency. This neurology rotation made me realize even more of how important it's to have a good knowledge in both. So I found this very interesting article written by some residents and physicians in both specialties. Here we can see Dr. Brown and all his colleagues. So they propose a new model should emerge so the people going into these fields have a good knowledge in both areas. So I will be sharing this with you. So, the first question they did is, when I have a problem with my heart, I go to the cardiologist. When I have a problem with my kidneys, I go to the nephrologist. What happens if I have a problem related to my brain? Where do I go? So this is how it usually works. If you have a behavioral problem, you're sent to the psychiatrist, unless it's degenerative. Then you're referred to a behavioral neurologist. And if the problem is motor and sensory, then they send you to the neurologist. Unless it's non-organic, then they are sent to the psychiatrist. So in the late 1800s, these two very interesting and intelligent men, Jean-Marie Charcot and his student Sigmund Freud, did the classification of hysteric or functional versus organic disease, which basically means structure versus function. But clinically, there are no defining rules to divide brain diseases into neurological versus psychiatric. So they made these 5 questions. Why do we practice medicine this way? How many diagnoses have been missed or harmfully delayed? What happens when a patient has brain disease that crosses this imaginary boundary? How often is the best treatment outside of our scope of specialty training because that treatment is used to treat another aspect of the brain? How can we know what we don't know? So we are still using this late 1800s definition despite all the advances in knowledge and technology. Symptom-based diagnosis created by clinicians, they're a very useful language, but they can certainly not map onto the underlying neurobiology of the diseases. So what has the National Institute of Mental Health done to try to break this thin line? So they created the RDoC, which is the Research Domain Criteria Initiative, where they did this. So for each of these parameters, they created a matrix where you have to point genes, molecules, cells, circuits, physiology, behavior, self-report, and paradigms. So we are witnessing to the greatest neuroscientific era in history. An etiological approach will continue to shift more psychiatric patients to the care of neurologists who are not trained in psychiatric management. And at the same time, with this new era of diagnostic biomarkers and all these neuroscience-based precision treatments, it requires a lot of skills that are not available to every psychiatry resident. So we realize these are complementary skills, but there's 2 big questions. Do neurologists have the necessary training to care for these patients? And do psychiatrists have the necessary training to implement and interpret all these new tests? So currently there are yearly 3 to 4 positions offered to the dual program in psychiatry and neurology, which is a 6-year-long program. In the neurology programs, we can see here, usually this is a generalization, not every program works like this, but you spend 1 year in general medicine, then you do your neurology rotations, and usually you just require 1 month of psychiatry. Whereas in the psychiatry residency, you do 6 months of general medicine, you do this amount of psychiatry, and then usually 2 months of neurology. So Brown and his colleagues proposed a different training model called brain medicine, which in the first 2 years, both will all have the same scope of knowledge, the same breadth of knowledge, and then you can subspecialize. I mean, they do stress that it is evident that subspecialization will become increasingly necessary with all of these advances, but they propose this model. So as I said, the first 2 years, everyone will do 4 months of general medicine, 10 months of neurology, and 10 months of psychiatry. And from years 3 to 4, you can decide where you want to go. They created a schedule with their proposal to see how it could work. And now I'm going to quote them. The neuroscientific revolution is erasing the line drawn between disorders of structure and function. Medical fields were defined on the basis of what could be seen with the naked eye or with a microscope at autopsy. With advanced brain imaging, neurophysiological techniques, sophisticated animal models, and cell cultures, it has become apparent that all brain disorders have their basis in brain structure and that all brain disorders affect brain function. However, clinical training remains stuck behind these boundaries. So, when I read this article, I found it very interesting. It's a fresh perspective, and for those passionate in neurosciences, it would mean not having to choose between one or the other, which is wonderful in my opinion. It's evident that there are many complications that would be faced when trying to change how things have been working for a long time because it takes a lot of effort and a lot of time. So why is this important? It's important to have understanding of the whole brain in order to become more aware of what we don't know. Patients would be able to get a physician who can guide them in a better way. It may also help further destigmatize psychiatry by calling it brain medicine. And it will be less year in training for the residents. So, with this last part of the presentation, where I talk about the article written by Brown and his colleagues, which I personally agree with, I do not intend to give a correct or incorrect posture on how programs should be. I just intend to open a question for all those interested in neurosciences to explore the need of having a bigger breadth of knowledge in both specialties to be able to help our patients in a better way. So thank you so much for your attention, and I hope you enjoyed it.